So this is the micromotor and this is the way we use our Gates Glidden drill. So we put it like this, lock it. So this is the Gates Glidden drill number 1. The Gates Glidden drill has a long thin shaft ending in a flame shaped head, as you can see, with a safe tube to guard against perforations. The flame head cuts laterally and used with gentle apically directed pressure. The long shaft is designed to break at the neck, the narrowest diameter that lies adjacent to the handpiece. If the drill binds during use, it will fracture at the neck of the shaft and will extrude from the tooth. The fractured segment is easily removed by grasping the broken shaft with pliers and pulling it out of the tooth. It is mainly used to remove the lingual shoulder during excess preparation of anterior teeth and to enlarge the root canal orifices. In place of using the SX file, you can also use the Gates 2 and Gates 3. So just like that, you have to make the entry only till this point, only just where the drill is there. If you enlarge it totally inside, it may cause ledge formation. So just remember, using the fingers very slowly, finger rest, just insert it little bit and just take it out. So this is the use of the Gates Glidden drill. So now I am doing the opening of the premolar tooth. As you can see, I have mounted many teeth and I have filled with temporary filling so that it's easy to understand. So what you have to do is, so the premolar tooth has a buccal cusp and a palatal cusp, and the pulp hun are just directly present on the buccal cusp and the palatal cusp. So how you have to make the SS opening is you just have to make a punch hole. So at one point you will get the bud drop. Till now I have not got the bud drop. But again I will try it for one more time. Yeah, it's done now. So I have achieved the bud drop. Now I will show you. This is a 3-way syringe. Already we have started seeing the canal. So as I had shown you in the anterior tooth, we'll just check the patency and see how I have made the opening. The opening is oval in shape and one side it's a bucco-palatal opening. It's not like mesodistal opening. So this is the buccal side, this is the palatal side. So I insert it here and it's going nicely in a watch winding motion. Number 8 file you can see. Then again palatally you can see here. So I have got both the canals and you can see both the canals like buccal and palatal. Now what is your duty? Your duty is to remove the extra dentin which is lying above it, and you have to reach your file till the apex of the tooth. Now what you will do is you will insert this file into the patient's mouth. One more file you have to insert it palatally. After inserting both these files, we have to take an X-ray and know the working length of the tooth. I have already noted down the working length of this tooth. It's around 18.5 mm for the buccal cusp and 19 mm for the palatal canal. So now again with watch winding motion, we'll clean it. Similarly, like the anterior tooth, we will irrigate it again. Irrigation in both the canals, this buccal canal and palatal canal. After irrigation, we have to widen the apex of the tooth. How will we widen? We will just widen with the SX file for the beginners. So start with the SX file, just this much rotation, then reverse 90-degree rotation, 3/4 and 90, pull it. Similarly palatally, 3/4 and 90, pull it. So now my Gates Glidden drill is moving at a medium speed. Now how I do the coronal flaring? So just I put it inside little bit, just little bit, and see how wide my canal is looking now. The first is the coronal flaring file or the SX files. Instead of it, we can also use the Gates Glidden drill. So this one you can use in only 5 to 6 canals. This one you can use in many canals, around 15 to 20, but you make sure you autoclave them. Then is the S1, shaping 1, shaping 2, F1 and F2. Similarly, in this tooth, we have to use this SX, as I showed. SX you can use, or you can even use the Gates grid and drill with the micromotor. Then the shaping file, around 18 mm, you have to set it around 18 mm. So this is the endo block, we have to measure it till 18 mm. Use only Dentsply endo block, it's the best. I am using this since 5 years. See, the condition is so good. So this is our tooth. We have to set the measurement. We have to shape it. Shape it, both the canals. One canal 18.5, the other one 19. Shape it like this. Then same S2 file. We again have to measure it 18 mm. Before that, we have to do the irrigation with saline or sodium hypochlorite 5%. After irrigation, we have to use the S1 file, shaping file, 3/4 rotation, 90-degree back rotation. Then the F1 file, which is the last file for the premolars. So all the endodontic instruments are available in 2%, 4% and 6% taper. You must have heard people talking about this. Taper denotes the per millimeter increase in the file diameter from the tip towards the file handle. So in other words, a number 20 file has a tip diameter of 0.2 mm and would have a 0.22 mm diameter 1 mm from the tip, and 0.24 mm 2 mm from the tip, and 0.26 mm 3 mm from the tip. So greater taper instruments have been developed which are around 4%, 6%, 8% and even 10%. Tapered instruments help in preparing canals of wider diameter without over enlarging the canal at the working length. Thus a 30 size file with 2% taper, 30 size file with 4% taper and 30 size file with 6% taper all would have the same tip diameter of 0.3 mm. This F2, this is the F1 file, 3/4 rotation and reverse rotation and pull. Similarly in the palatal canal, as you can see here, 3/4 rotation, 90-degree rotation back and pull. So you see how nicely the canal is being prepared of both buccal and palatal and buccal sides. So before starting of the rotary root canal, rotary RCT or rotary endodontics, so first we should be well versed with the endomotor. So this is a basic endomotor which is radar, and the price is also very economical. So where you have the handpiece where you can attach it like this. So you should oil it here, not here. It contains the battery and the motor. And on switch, you can see various numbers like P2. This is program. So there are different programs. First of all, we'll check with that. So P3, P4, P5, and first number denotes the program. Suppose P1 and the rotation is 550 revolutions per minute and torque is 550 and the torque is 2, and this is not in the auto reverse mode. This is just in the forward mode. So suppose we want to change the RPM. What we have to do is we have to press this button set, and then you can increase it or you can decrease it. So we have set the revolutions to 200. Now you want to change the torque. Suppose the torque is 2 and you want to reduce the torque on the endomotor. Then you can reduce it by pressing this button. So now see, I am reducing the torque. Next I want to change the setting to which mode I want to keep it. So we can change the mode by again pressing this button. You can see the modes are changing. So this is the auto reverse mode, and where the endomotor will automatically reverse when it gets any kind of obstruction. So this is set. Suppose again I want to set it. Second, P2 I want to change to 500 RPM and 2 torque. So what I have to do is, again I have to set S, then I have to increase it to 500. Then again we have to press the S, then we have to increase the torque or decrease the torque. So it's very easy, and usually I tell my beginner students to just use the auto reverse mode instead of any other mode, because that is the easiest mode to use. So this is the maxillary first premolar tooth. As you can see from the sides, it's the buccal cusp, and this one is the palatal cusp. So 70% of the times the root are separated, but this is 27% of the time the root are fused. But this tooth is having two canals, as you can see here, the buccal canal and the palatal canal. Usually the palatal canal is much wider than the buccal canal. This one I have already prepared it for you guys. Now next we are coming on to the maxillary second premolar. Here also we can see the two canals are there, and this is quite close to the maxillary sinus. So all the premolar tooth are slightly tipped towards the distal side. As you can see here, the root tip is slightly distally curved. So 30 to 40% of the times it's curved. So this is the maxillary molar tooth, which is having three roots, and it is the palatal root is quite in proximity with the maxillary sinus. So we can see there is a mesobuccal cusp. So the mesobuccal canal is just underlying the mesobuccal cusp. Then below the mesobuccal canal is the MB2 canal. Here we cannot appreciate it, but it is usually in the line connecting the mesobuccal canal and the palatal canal. Somewhere in between you will find that palatally. So here we are looking into the CBCT of a maxillary molar, and this is the pulp chamber, and as we go deep inside we can see that there is a MB1 canal, MB2 canal, distrobuccal canal and palatal canal. So the MB2 canal is just palatal to the MB1 canal, and this is the maxillary sinus. Then there is the distrobuccal canal. So this tooth is always carious, so I have already prepared it. Not an ideal tooth, but this is just to show you the roots. So it is having the largest pulp chamber, the maxillary molar tooth. So now this is the maxillary third molar. As you can see, the roots are fused, and I don't suggest to do the root canal of the maxillary third molars, because usually it is a vestigial and better to extract it. Now we are coming to the lower anteriors. This is the lower central incisor, as you can see, and the root is quite straight. So one important thing that you must be knowing, that there is only one canal, but in few cases, 30% of the cases, we get two canals in the mandibular central incisor. Now you can see the CBCT here. So this is the lower central incisor, and we can see two canals here which are filled. This is the Gatapaka. So this is the axial section. These are the two canals of the lower central incisor. We can clearly appreciate. So this is the access opening point, and the two canals are getting divided like this. Where you can see there are two canals in the lower anterior central incisor teeth. Now this is the mandibular premolar. You can see it's the close proximity to the mental foramen, and the root is also curved. Sometimes during the infection of the mandibular premolar teeth, the infection can reach, or you can injure the mental foramen, which can lead to paresthesia. So be careful while doing the RCT of the mandibular premolar teeth, as sometimes what happens is while giving the local anesthesia or during any kind of procedure, you may injure the mental nerve which is coming out of the mental foramen just below this teeth. Coming on to the mandibular molars, the axis shape is rhomboidal in shape, and you can see there is a distal canal which is quite wide, and there is a mesobuccal canal and a mesolingual canal. So most of the file breakage occurs in the mesobuccal canal of the lower molars, if you don't know. So it is having two roots, one mesial root and one distal root. So this we have to keep in mind. So this is the buccal cusp and this is the palatal cusp. So this is the axis shape, and this I have already done the opening. I will show you again in the demo. So now here you can see a set of various files which are kept. So this is the coronal flaring file. This is the path file. This again is a path file. Then this is his shaping file. This is also shaping file. This is also finishing file. So you can use this sequence as we use in the pro taper. The color coding is same, like purple, then white. It's a 15 number file. We call it as a 4% 15. Then this is the 4% 20. This is the 4% 25. Similarly, there are many different files of various different tapers. So this is all 4% taper files. So this is the coronal flaring files. For the beginning, you just need to know the sequence. After that, in the advanced course, in the later classes, I'll be telling you regarding what file systems, whether you should use a 4% or 6%. So this is the SX file, and this is the way we are inserting in the endomotor. You just have to press this button and just we have to insert it, and you can hear a slight sound which ensures that it is nicely stuck to the endomotor. So what happens sometimes is when you are using it on the patient, sometimes it gets off from the endomotor and gets stuck in the tooth, and it is very difficult to take it out. So this is the SX. So here I am already setting the endomotor to program 1, which the RPM is 200 and torque is 1.6. So and this is the LED which is there. So anything above this torque, it will auto reverse on its own. See, it's auto reversing. So if I press it like this, it's getting auto reversed. So these are the file systems which I am using. So this is a variable taper path file from Woodpecker. This is so you can see two files are there. So one file is 21 mm, the other file is 25 mm. Sometimes the canine can be very long, so we can get files as long as 31 mm also. So if the working length of the tooth is 19 mm, you can use a 21 mm file. If the working length of the tooth is more than 23 or 24, you can use this 25 mm file. So this is a path file which is variable taper, and about taper I have already discussed. So this is a 4% 15 file, this is a 4% 20 file, this is a 4% 25 file. So I usually extend my canals till 4% 25. So I'll show you how to fit the endomotor along with this file, and just you have to press this button which is just on the back side of the endomotor handpiece, and you just insert it like this and give a slight rotation. And it will make a small sound. So now you have to see what RPM it is there. So I have set it to auto reverse 250 RPM and 1 torque. For the beginning you can do with less torque, and this one I have already shown you with the files, and this LED is working nicely. So I'll just remove the LED because it's too much light. So you can see here how I am inserting the file like this. So what is the advantage of rotary? Rotary RCT, you can do the root canals very fast because you are not using your fingers, you are just using your wrist. So just a motion like this. So since I have already prepared the canal, it's rotating freely. For example, I want to show you the auto reverse function. So directly what I'll do is I'll fit the 4% 25 file in this, and see whenever the canal is getting some kind of obstruction, see it's getting auto reversed. So I put it in the buccal canal, now I'm putting in the palatal canal. See, it's getting auto reversed if it is getting some kind of binding or some kind of obstruction. So similarly, what initially file I have used, so after this I have to irrigate, and then I use the number 15 file. Again I have to fit it like this. I hope you are finding this video useful. So after the 10 number file or the path file, we are using the 4% 15 or 4% 20 file. This is 4% 15. Various companies are having various specifications, like I am using Neo Endo, sometimes I am using Hero Shaper Gold, sometimes I am using Pro Taper Next, sometimes I am using Sidga files. So there are many companies which will give you various deals, and various numbering systems are there. So the common ones are, so this is a Neo Endo file which I am using. This is a 4% 20 file. 20 means yellow in color, 15 means white in color. So this is another file. So now I have inserted it. So since I have already prepared it, as you can see, so only one stroke has to be there. So now this is the last file which I am going to use. The RPM is set 250 and one top. So now you can see the gutta percha points which are available from 15 to 80 number size. So if you are using the K files, you have to use this ISO size from 15 to 40 and then ISO size 45 to 80. But this root canal system is very consuming and time taking. So we have shown in this video about the 4%, 6% files, and corresponding there are the 4% 20, 4% 25 gutta percha as well as the 6% 20 gutta percha. So here you can see the color coding. The white is for 15, yellow gutta percha is 20 numbers, 25 number is simultaneously all the color coding which I have shown you earlier for the files. It is same as of the gutta percha. So these are all 2% gutta percha. Now coming on to this is all 4% gutta percha. So you can see the size is a little bit thicker than the 2%. Now then you can see the 4% 25 gutta percha. And this one is the 6% 20 gutta percha. 6% 20 gutta percha files or GPs we have to use in the palatal canal of maxillary molars, as I have told you already, and on the distal canal of the lower molars. Similar to the gutta percha, we have the absorbent paper points, ISO paper points 45, 50, 55, and we have the 4% paper points as well. So we are going to use the 4% 15 paper points. So it's available in various sizes. I use the 4% 15 ones or 4% 20 ones, 4% 25 paper points. So we have already done the BMP of the premolar tooth, and now we are going to seal it with gutta percha. So after proper irrigation with 5% sodium hypochlorite solution, we have to do it EDTA solution so that all the dentillary tubules open, and after that we have to insert 2 paper points so that all the canals become dry. So this is the way we have to insert it in the canal. So this is the way. So we have to keep it for some time so that the canals become dry. Then after that, so this is the sealer which I am using, Seal Apex, and we should always use a good quality sealer, and already I have mixed it to this consistency. You just have to apply it onto the gutta percha. After application in the gutta percha, what you have to do is you just insert it in the canal, and little bit you have to rotate the gutta percha, and it should be snugly fit into the canal. So after putting this inside, so this is a ball burnisher which I am using to seal, and other instruments are also available which is like battery operated, and so I am just heating it. So you have to heat it till it is red hot. Then you just have to insert it and do like this. So your canal is sealed now. Now we'll do the other canal. So now again we are putting the sealer across the gutta percha, and now insert it into the canal. To work in a patient and to work in a dummy, there is a lot of difference. So to heat it red hot. And just little bit for a second, you have to just do this, and you have to be very careful in the patient's mouth. I suggest use the suction so that the smoke which is of the sealer which is coming out is get sucked by the suction. So now your tooth is sealed. Now you have to fill this with either composite or glass ionomer cement, and you have to send the patient after that. Then you have to send the patient for crown cutting or whatever procedure or whatever process you want to place. So that's all with today's video.